it was very similar to what we're finding in other cities, and then the symptoms depending on their age. Same thing that we talked at the beginning, when they were infants, they were more have failure to thrive, feeding refusal. More toddlers will have more abdominal pain, and the older they get, they start developing more dysphagia. So as a clinician, you see a patient come in 12, 30, 13 years old, asthma had to be you start asking, kind of dig into the dysphagia part, because it might be there. So we actually found that, and we published it, and it got accepted at a NASPGHAN in a poster, and then another allergy immunology conference that Dr. Lance had presented 2 years ago.
Welcome back to another PGA podcast. We have a special guest this afternoon, Dr. Richard Arboleda.
Thank you for having me.
Part of our group, PGA. And topics today is going to be eosinophilic esophagitis. And Dr. Arboleda, throughout the year, he has developed an expertise on patients and kids with this type of disorder. So let's dive in.
Okay. Well,
so can you give us a little bit of your background? So how you ended up here with us?
Sure. Yeah. So I initially, as a medical student, I actually did some rotations here with Dr. Munoz and Dr. Reeves, and they're actually my mentors as a medical student. So I already knew I was interested in GI from a long time. It's just I didn't know if I was going to come back. So luckily, after I finished my fellowship training at Vanderbilt, I did a lot of studies more in H. pylori, the immune system, and things like that. And since I kind of liked immunology, allergies, I did a microbiology background, so it was there, but I didn't know it was like part of my passion until I actually came back here and started here about 12 years ago. And then for the last maybe 4 or 5 years, it's picked up a little bit. You actually got me in contact with one of our local allergists, Dr. Lance. And then we started doing a couple of epidemiology papers and things like that. And then from there, it just grew into, part of what we're interested in addition to other things. So I'm here for the last 13 years. I'm happy to be here, and hopefully I can.
We are happy to have you here too, helping us with complex patients with eosinophilic esophagitis or gastrointestinal disorders. I mean, during this talk, I would like to hear a little bit more about what you've done in terms of the epidemiology and some of the publications and presentations that you have done. So in terms of eosinophilic esophagitis, what is eosinophilic esophagitis?
So in trying to put it in easy terms, it's kind of complex, but usually it's like a chronic immune mediated response. It's called the Th2 response, where there's certain white blood cells, they're called the eosinophils, that sometimes are exposed to certain proteins or certain conditions. They can cause inflammation. And in this case is particularly to the esophagus. We're just going to look at the esophagus because there's other conditions once we leave the esophagus, but we'll focus on the esophagus. So this type of reaction can cause localized inflammation, where if it's not taken care of long term, can cause what this remodeling, fibrosis. And then, if we have patients who are not diagnosed early, they sometimes present to us in adolescence, even though they have symptoms when they're young, with food impaction or failure to thrive and things like that. So it's kind of a clinical histological diagnosis, meaning we have to look at the clinical and the histology. But usually the epidemiology of it, what we learned, is is 50 per 100,000 kind of worldwide. And we learn that it's most specific or more common in young males with atopy and other allergic conditions like eczema, allergic rhinitis, etc. So that's kind of the group that we look into, even though you have to look at different groups.
So in terms, just for me to recap, so in terms of a concept, eosinophilic esophagitis is a chronic inflammation of the esophagus of the patient, and characterized by this abundant amount of cells that we call eosinophil, that it seems like it have an immune-mediated kind of a background of etiology, and we're going to talk hopefully a little bit more about that it seems that it's mediated by a type of cells within the immune system, which is the Th2
Correct.
response, or T helpers type 2 response. So that there is any risk factors now that it predispose pediatric patients or kids to have eosinophilic esophagitis?
Yeah, that's a very good question because that type of information, there's different. If you look at different literature, you'll see different things. So one of the things that they're actually talking about recently, there's some type of genetic components that they have found. There's a specific chromosome, I believe it's 5q22, what it does, it has to do with the cell barrier function. So if there's some type of problem in that barrier function, you might be exposed to certain
Yeah.
allergens and things that might cause this reaction. There was also some recent studies looking at the use of PPIs in young babies that would sometimes can increase your chances of developing allergies later on. I don't know if this is more of a IgE mediated versus the Th2, but just one of the factors that I kind of read up in that case in terms of that, and then also reading in other countries where they have higher prevalence of other parasitic infections, for example, H. pylori, which is a Th1. They actually is protective because they think it might be your immune system might be shifting towards one Th1 and not the Th2, and that's actually protective. But some of the common factors would be more like genetic, environmental, but it's hard to find one specific variable in that case. But those are kind of the two that, kind of top of my head, I remember.
So it
That's been
seems
there.
that there is some genetic predispositions towards the inflammation in the esophagus that is mediated to this protective barrier, mucosa barrier of the esophagus. And like you say, I mean, there is a chromosome and maybe a gene. I think it's a CAP N14, something
Yes.
like that. And there has been other genes associated with this, like eotaxin 3, which is a gene, I believe, that is linked to recruitment of
Eosinophils.
eosinophils towards the mucosa and so on. Now, in terms of environmental factors, so it seems like in patients who've been previously exposed to parasitic infections, or kids who had or persons to have had a parasitic infection, they may be protective
Correct.
because they have kind of a more balanced immune system. And these people have called that in the past, I believe, the hygiene hypothesis.
Correct.
And now in terms of diet, I think I came across also like it's less common in kids or in persons who has been less exposed to antibiotics in the past, and that's part of the hygiene hypothesis, or kids who has been exposed to significant amount of breast milk during infancy or after birth. So it means like it may be protective against EoE. And I believe also that it's also a link to, like, it may be more predominant, you tend to see more eosinophilic esophagitis in people who were born through C-section rather than vaginal delivery. So, but that's part of also the hygiene hypothesis.
And the whole microbiome.
So the more natural everything is done, less antibiotics, vaginal delivery, exposure to breast milk. So it seems like your microbiome, exactly as you're explaining that up, it's going to be a better microbiome, more robust microbiome, and less chances of immune-mediated mechanisms leading to inflammation, and less abnormal genes.
Exactly.
So once the patient has established eosinophilic esophagitis, could you remind us the symptoms or the type of discomforts that they express, the patient?
Yes, of course. So it usually depends more on the patient's age. Most of the time, average age I see is about 10 years old, but I've seen young babies up to young as 1.5 or 2 years old with symptoms. So if in infancy or younger, they'll present with more vague symptoms. So maybe a feeding aversion, some type of reflux or failure to thrive, or maybe suspected something else, maybe reflux or another type of allergy, and they're not getting better with certain treatments. As they grow older, in toddlers, they present mostly with the most common one that we saw in an epi study was abdominal pain. Abdominal pain was the most common one, and sometimes failure to thrive. As you start getting older, meaning 10, 11, 12, then this is when we start seeing our patients more with like dysphagia or what they call difficulty swallowing. So it's always important to ask them the right question, because sometimes you ask, do you have difficulty swallowing? They're like, no. And you're okay. Do you chew your food extra to swallow it, or do you drink extra water all the time? And then they kind of have a compensatory mechanism to do that. And those are the things you have to find out. So most of the time in older kids will be more dysphagia or food getting stuck, or chewing the food a little extra, in that sense. Um,
So let me know if I'm correct. So the older you are, the more difficulty swallowing kind of symptoms you're going to have as a patient. And I believe that that may be connected to chronicity. So meaning the older you are, the longer you have inflammation, the more remodeling of the esophagus you had, and more scars or fibrosis. And that lead to narrowing of the lumen of the esophagus and then the dysphagia. Is that correct, that assumption?
Correct, correct. That's what I always tell like my patients. Like when you get a cut and you heal it, what's left is scar. It's like fibrotic. So if you have constant inflammation and remodeling, that with time it will progress, and that's kind of the progression of the condition.
I have patients in my practice with other associated conditions. Have you seen that in your practice too, like a eosinophilic esophagitis associated to any other gastrointestinal disorders?
Yes, yes. The most common would be eczema, atopy, and you see them like when you examine them. Something they have a history of eczema, atopy, also asthma. You see them a lot. So just those are always key questions to ask when you're trying to get the whole picture. However, there are other things that overlap. I've had some other patients that actually it looked like EoE, but it ended up being celiac. And then there's some patients that actually have inflammatory bowel disease, and with the same similar findings in the esophagus, and we treat the inflammatory bowel disease without having any type of restricted diet, and they get better. So yeah, they're more associated, but the most common would be like atopy, eczema, asthma in young males.
Yeah.
It seems to be more than
Yeah, that's
female,
very
interesting.
interesting. And,
Yeah.
so it seems like it's in a group of patients, this Th2 response, it goes beyond the Th2 response. So they have another abnormal molecular or immunologic mechanisms linked to other conditions associated to eosinophilic esophagitis, exactly as a celiac disease or inflammatory bowel disease. And actually, I've seen patients also with type 1 diabetics. So eosinophilic esophagitis, celiac disease, and type 1 diabetics. But it's interesting that points that you are mentioning on eczema and asthma, because some patients may have also like an IgE mediated mechanism involved, which
Correct.
is not only the plain Th2 response, which that probably is going to take us later on to testing and so on.
Correct.
So now you're suspecting that your patient has eosinophilic esophagitis based on the history, based on the family history, uh, um, symptoms of the patients. So what are the type of tests that you do in these cases to identify the condition?
So in this case, the gold standard would be to take a look histologically, to do an endoscopy. In the meantime, if you want to rule out other things before you do the endoscopy, we can check for other conditions, or look for anemia, celiac serology, make sure they're not malabsorbing, or other conditions that might be through the rest of the gut. So look albumin, calprotectin if you think it's more inflammatory bowel disease. So initial workup, but the gold standard would be to do an endoscopy, to take samples and the three levels of the esophagus, including then the stomach and duodenum, and then look under a microscope to see what we see. If we find certain findings that would be more consistent with eosinophilic esophagitis versus something else like celiac or H. pylori or something else in the other
How
bits.
safe is doing an endoscopy, an upper endoscopy in kids?
So it's I always give this talk to my patients. It's very very safe, but there's always a percentage of they might get a fever, infection, or what we call perforation. That's less than 0.1% of our cases, but it's fairly safe, but that's something we always have to keep in mind in terms of later on following up. Then this is something we have to consider in all our patients. So it's fairly
Yeah.
safe, but like anything else, there's always risk and benefits. In this case, the
Yeah. So
benefits more than the risk.
the patient usually requires anesthesia, but it's a very short procedure. So it usually takes 3 to 5 minutes. That's what I tell my patients,
Yeah,
and then the side effect of it is just minimal.
right.
So we do hundreds of these, and we don't see many of these. So when you do an endoscopy, what are the findings you are expecting to see in a patient with eosinophilic esophagitis?
So when doing endoscopy, it also depends on the level of inflammation, the patient's age. So most of the time, when you see some type of find the eosinophilic esophagitis, you will find the mucosa looks edematous, meaning it looks swollen, sometimes some irritation, and then most of the time we will find these findings called linear furrowing, which is these small lines that look kind of like train tracks. And those are just small micro abscesses that you can see in eosinophilic esophagitis. Also, when you're putting in the endoscope, always be careful. Always go in slowly because some of these patients might have a little bit of narrowing or some resistance that you can't pass the endoscopy, and that's when you can sometimes get into trouble. But the most common finding would be redness, edema, some linear furrowing, and then usually if it's really chronic, just you see more in adults. It's called trachealization, where you see these rings that look like your trachea,
Yeah.
but it's in the esophagus. But we don't. I haven't seen a lot of those, and at least the patients I've done to this point, it's mostly the linear furrowing that we find.
Yeah, so that esophagus would be like a super beat up, chronic inflamed esophagus that are leading to this amount of like kind of a ring. So
Yeah.
of exactly what you described, trachealization of the esophagus. What are you expected to see on the biopsy results of these patients with eosinophilic esophagitis?
So in the biopsy, we look for certain things. So sometimes we have expansion of the lamina propria. You have these eosinophils, which kind of go up to the surface, and there's a certain amount of numbers that we talk with the pathologist to kind of help us differentiate. So the reason why we always do 3 levels is that sometimes you'll have like the number that's established is more than 15 eosinophils per high power field. But the reason why we do in all 3 levels is that sometimes, let's say you have a little bit of reflux or some irritation in the distal esophagus, and you have like 5 eosinophils, but then the other 2 look normal. Then you're like, well, it might be more of a reflux. But then if you see 15 on the bottom and then 100 in the middle and 15 or 20 in the top, then you know it might be more of eosinophilic esophagitis. Obviously, we always want to rule out other things. So if it looks, sometimes it'll look fungal. So we'll look for fungus, and the pathologist helps us do some stains. Or sometimes they have viral inclusions. So we'll look for CMV, HSV, etc. In those areas. But most of the time will be what we call an eosinophilic count.
So you remind us before that this is not a immunoglobulin E mediated type of food allergy. It's more like a T helper response or delay reaction. If you had to do further testings on these patients, would you do allergy testings? The type of allergy testing that would you recommend? Would you recommend any? When to do it, when not to do it?
Right. So it usually depends when I see them. Usually I tend to do the endoscopy and these things before the allergy testing, unless there's other symptoms before that I saw. So that's always $1 million question, right? Because these allergy testing, the skin and the IgE the tests are the RAST are IgE mediated, meaning that you have antibody, it binds to a certain cell called a mast cell. They secrete histamine, and you have a local reaction or a systemic reaction, what they call anaphylaxis. So that's always $1 million question because you can do those tests, right? So now, actually, the new recommendation is saying the tests aren't good to tell you what to eliminate, but if some of them come elevated, then you at least avoid those in the introduction because you can have a strong reaction to. And the reason why I say that is that I've had patients who have very bad EoE, and you do the allergy testing, which is IgE mediated, is different, and it all comes back negative. or vice versa. It all comes back positive and they don't have any findings in the histology. So I think that's extremely important to kind of know how to interpret. Look at the labs, look at the clinical picture, and then if some things might be causing anaphylaxis, then I would avoid those. But now they're not, we don't do those to tailor what kind of elimination diet we're going to have in our patients with EoE based on kind of what we've learned in the new guidelines.
Yeah, I agree with you, and I think, I mean, you are able to find out a group of patients that have this mixed pattern of IgE T cell mediated kind of food reactions or eczemas or environmental reactions that you can kind of tease out. But the gold standard is no allergy testing so far. I believe it's just more like a diet and medicine and all based on how the patient responds. Now, so it's pretty much clear now that the patient has EoE or eosinophilic esophagitis. So how would you treat that patient? So in terms of diet eliminations, the type of diet eliminations that you would do, and let's start first there.
So it all, I would say it all depends on the individual, right? Because if it's a young toddler, let's say 4 to 5, where you can control more of their diet, sometimes you can pick what's called like an elemental diet, which is a strict amino acid based diet, initially to see if that can help us out. They have the parent there to control that diet. The idea would be, let's say a patient, we see this and parents like, you know what, I want to try this before doing other medications or any topical things. So we usually do it for approximately 2 months, and see how they're doing the symptoms. And then at least we do 2 to 3 months. And then we do an initial repeat endoscopy to kind of see if they're responding. However, let's say it's an older patient, maybe 10, 11. It's hard for them to be so controlled with their diet because they're in school and they can't control that part. Then there are other options that we might have, which are like a topical steroid. There are two that we've used in the past. One is called fluticasone, and the other one is called budesonide. Would be another option for that. That one works pretty well too. We just have to make sure that when they take it, they have to rinse their mouth really well after. But with, that's something we've tried to in the
Would you
past also.
use before starting on the corticosteroids diet and proton pump inhibitors ahead of the corticosteroids, or you do the combo of diet, PPIs, and corticosteroids straight?
So usually, and when I finished fellowship, based on those guidelines, they actually were separating the response to PPI and eosinophilic esophagitis. So at that time, initially, we would do a PPI trial, proton pump inhibitor and diet for 2 months, and then we'll repeat the endoscopy. If they improve, then we would say it's a PPI response of eosinophilia and not EoE. However, there's been a lot more studies coming out. There was a meeting in 2018 called the Agree, meaning that where they looked at the mechanism of eosinophilic esophagitis, and they thought it was more a problem with not the eosinophils, more the permeability of the esophagus that can cause these exposure to inflammation, and they looked at the PPIs actually helped decrease some of those factors, including interleukin 13 and stat, which are both kind of messengers to help that. So in the past, yes, I would do that to rule it out. And now with the new recommendations, you're right. A PPI actually it's the initial treatment in addition to either the diet or sorry, I blanked out,
Corticosteroid.
or the corticosteroid. But
Topical
yes,
corticosteroid.
the topical corticosteroid. Yeah, but PPI now, in the new recommendations by Aspigen, recently we had a single topic symposium in Aspigen, and that was a big thing that they talked about now, that actually the PPI is part of your initial therapy, and there's some reports that up to 50% of the patients can respond to that alone. Interesting though, there was some variability, some phenotypes that they had on two specific phenotypes, that if they have that phenotype, they usually don't respond well to the PPI. So maybe in the future, if you're thinking about doing a PPI, maybe you can screen them before doing the PPI. But
So it seems like you're probably going to need a combination of the three.
probably.
And so now your patient is responding to this therapy. Would they need medication lifelong, or you do diet and medicines and then you just giving a break on the medicines and then just continues on the diet? It seems like, based on what you're telling us, that these patients, they will need endoscopies often because it's the only way to assess if the inflammation is improving or if it has resolved. But would you do so? What is the length of treatments in medical treatments that you would do for these kids?
So for this at this point, it is, I guess, lifelong. But for lifelong for us is about 18 to 21 years of age, right? Because then we lose them or they leave. But the initial treatment will be a higher dose. So for example, the PPI would be a higher dose for those 3 months. Repeat an endoscopy, take a look, and then what we'll do from there is kind of see a combination. If they want to continue that, maybe we can try a lower dose, with less a side effect profile, or if they prefer to maybe add a topical steroid, or add or eliminate only certain foods, right? So we'll talk about that later, about like there are more ones that are more allergenic, and we can try that. But at this point, it has to be lifelong. Because there's been studies where people have stopped it after 2 or 3 years, kind of where the maintenance we talked about, but the majority of them would relapse. There's a couple that don't relapse, but that's not the rule. That's the exception. So at least for now, I would be at least 2 to 3 years. But if they're younger, then I would at least until they're 18 or 19, and then we can decide if we might have to change the treatment based on if they leave, go to college, or things like
Yeah.
that, which we
And,
have talked about.
any concerns in terms of long-term use of either proton pump inhibitors versus corticosteroids? So what are the things that you are going to be looking at to see that your patient is not having any side effect for the topical corticosteroids?
Right, right. So the most common for the topical corticosteroid would be like oral candidiasis, or upper respiratory tract infections. There's always a concern. The big concern would be on adrenal suppression. There's some studies that say it might slightly cause adrenal suppression, but most of those patients that have that are been on multiple different steroids, also for other conditions, so for asthma, eczema, and EoE. So those are the kind of the big ones, and also your bone mineral density. So like I do with our patients with inflammatory bowel disease or things like that, we do a DEXA scan, one every 1 to 2 years, check their calcium, make sure those are okay. But it's risk and benefits, right? And then if we can maybe do a lower dose, instead of,
So that will help.
that would help out too.
So we had to monitor the height of the patient and
Awesome.
bone health.
Correct.
They need to be on treatment for a long term. And in terms of the long term use of PPIs, any concern?
So PPIs, the ones you kind of look at more is increased risk of infection, like C. diff, because you alter the mucosa, the microbiome, and that can cause that. And then also most common would be some type of mineral deficiency, mostly magnesium and vitamin B12. It's also important to go look into that, and also bone growth, the bone health, the same thing we looked
Yeah.
in steroids. We also look in the PPI, or those are the most common
But
ones.
we've been using that for a long time. It seems like overall it's safe to use
Yeah,
in our patients.
I would, yes. It's the risk, the benefit is better than the risk.
Now, so in terms of dietary restrictions, what are the type of dietary restrictions that you offer to your patients?
So when I first finished fellowship, we start talking about the 6 food elimination diet, right? Which are the 6 most common food, which is milk, soy, wheat, egg, peanut, tree nut, shellfish. At that time, they actually had what they call like a step down treatment. So they'll
Hmm.
eliminate all that, introduce one food, and then 2 months later repeat endoscopy and kind of see an improvement, kind of go down. But that's very difficult to do. It's also difficult to convince a parent or somebody to do multiple procedures in that sense. So what's been happening now, they've actually come up with different ideas. There's one called that they called step up elimination. So they'll pick two most common allergenic foods, which is usually milk and wheat. So that's what I usually start my patients with first, and see how they do. So the idea would be, if you do those two and you repeat the endoscopy and it looks better, then it's one of those two. If
Yeah.
not, you can advance, eliminate two other foods and kind of go from there. So I've been trending more of to do milk and wheat, because sometimes we have celiac also, they gotta go together, and that's usually the two foods that I like to eliminate because it's feasible. You can get a quick answer, and it's not the different way. You save them from like 7 endoscopies from
Yeah.
introducing different foods coming the way down instead of stepping up.
So it seems like the most common type of food that linked to this inflammation is milk protein related products, and then probably gluten or wheat.
And we correct.
And it seems like the patient probably it would need some chronic dietary restrictions, so dietary restrictions for a while.
Correct.
Um, so any other type of treatments we are using nowadays to treat EoE, eosinophilic esophagitis?
So in 2022, there's a medication called dupilumab that they actually had been using for eczema and asthma for a long time. But they
And for
found
eczema, I believe that it's being approved for kids 3 years old or over.
it's no, I think it's 6 months.
6 months now.
6 months,
So
yeah,
wow,
and
so
it's
it's lower.
every 4 weeks. I'll tell you a
I
story
see.
about why I know that because I have a patient very similar.
Uh-huh.
But 6 months and every 4 weeks they give it. So they looked at since they're learning more of the mechanism of this TH2, how it works and the barrier function, how it affects it, they looked at certain interleukins. So interleukins are kind of messengers that send message to certain areas of cells to attract inflammation or immune response, etc. So they looked at two interleukins, which is interleukin 4 and 13. Correct? Yeah. Sorry, 4 and 13. And they saw that this medication was also helpful in the use of EoE in these patients. It initially started from 12 and above. So they had two studies. One, they used dupilumab, and there was another medication. I forgot the generic name, but they both helped with the histology, but the dupilumab was the only one that helped with the symptoms of dysphagia. So this was a medication that they saw that it worked and actually was approved for age 12 and above in 2022. And that's another option I've been using a lot, especially on patients who are a little bit older, not compliant, probably with their medications or their PPIs and things like that. I started to use it, and I've had really good results until this point with those patients. Now, fast forward earlier this year, that actually the same medication was approved for from the kids from 1 or above 15 kilos, and from
For
1 to 12
EoE.
for EoE. But it's interesting because they say it's approved for 1, but you have to be 1 and over 15 kilos. I don't know a 1-year-old who weighs 15 kilos. So the reason why I know that because I have a 1.5-year-old had very bad eczema and EoE, and we're gonna start to put him up, and they wouldn't approve it because of his weight. So he's actually on it every 4 weeks just for the eczema indication, and he's doing great. So maybe this is something we can look into later.
Yeah.
And turn that. So usually what the medication does is you start it for every weekly, and then you repeat an endoscopy in 4 to 6 months to see if there's any improvement. If they're already on a specific diet or on a PPI, I don't change that. So I don't want to kind of keep all the variables equal. So after the 6 months, if they're doing okay, then we can decide whether to introduce milk or something and then see how they do. But this is kind of the follow-up that we're learning now. What is going to be the surveillance of this medication, and what are the side effects that we...
So this is an injectable medication that is given subcutaneously. And I mean, I guess it depends on the patient. Usually every 2 weeks injections, or every 4 weeks. I think you can do it too.
It's indicated every week, but once they do better, I've changed it to every 2 to 3 weeks from my clinical aspect. That's what I do because it's hard to inject yourself every week. Sometimes you forget.
And like you say, it's a medicine that it blocks a cytokine. Interleukin 4 or 13.
4 and 13, correct.
And it binds both the receptor of the 4. I ended up blocking the 13 too. I'm going to ask you this question to see had you come across the most recent American guidelines. Reading the I think it was 2024 guidelines, European guidelines, they stay that patients with eosinophilic esophagitis should be on this hypoallergenic diet. You mentioned about that. milk, gluten, so on, and uh, and then trying PPIs and corticosteroids, and then those patients who fail because we don't have still long-term uh,
Like
safety
data. Yeah.
profile
Yeah.
in pediatrics. So it's better to wait longer on using the injectable medicine rather than the standard medicine that we've been using for the past few years. The American guidelines are telling us the same, to hold on the Dupixent for the patients who do not respond to dietary restrictions and PPIs or corticosteroid.
Yeah.
Is that the same guidelines that we have?
Yeah, yes, that's what it is for now. So kind of wait and see and try, and then use it if you failed.
Okay.
Even when you ask for insurance, when you're trying to get it approved from insurance, they ask you, have they
Mm,
failed either fluticasone, budesonide, or PPI is one of the indications. So yes, that is now, and I kind of agree with it. If we can do that, that's
yeah.
great. But if not, there's some patients, especially when I have three brothers that I took care of them when 16, 17, 18. They're all in college now. They don't comply with their medication, the PPI and all that, and they're on Dupixent, because you have to take that into consideration also. So it just depends. But yeah, I would definitely use it as a second line therapy for now, as long as we have more time and give us more time to look at the safety profile like any other medication.
So tell us a little bit about your research and publications with Dr. Lance
Oh,
and epidemiology
and
yeah,
yes,
what you came across and what you saw
yeah.
on your research.
So we just did a retrospective review of eosinophilic cases here in Miami. We actually got, I think it was about like, we looked at about
Uh-huh.
7,000, 8,000 encounters in our office. And then of those were about 200, I believe 220 cases of eosinophilic esophagitis. So we looked back to see what was their demographics, their ages, what were their findings, what were the most common symptoms. So it's interesting because when we did a epi study in terms of prevalence, it ended up being about 53 per 100,000, which is kind of, if you look at the epi studies, is very similar to what you have worldwide. And we found the similar findings of more common in males with atopy, eczema, and those are the kind of things we looked at too. So it was very similar to what we're finding in other cities, and then the symptoms depending on their age. Same thing we saw talked at the beginning, when they were infants, they were more have failure to thrive, feeding refusal, more toddlers will have more abdominal pain, and the older they get, they start developing more dysphagia. So as a clinician, you see a patient come in 12, 30, 13 years old, asthma, had to be some, you start asking, kind of dig into the dysphagia part, because it might be there. So we actually found that, and we published it, and it got accepted at a NASPGHAN in a poster, and then another allergy immunology conference that Dr. Lance had presented 2 years ago. So it was a good opportunity. Like you
Good.
said, you got in contact with him, and I called him, and he's been wonderful. And we share patients. We have a lot of patients in common, and some complex patients. And it's good to have a good allergist to kind of
Yeah.
feedback and back and forth. And also, he has a gastroenterologist that can help him and do the endoscopies that
Yeah,
he
so
needs to.
we, as a part of the cooperation, so a multi-group cooperation, we also use the allergies to help us on the treatment and follow-up of these patients as well.
Correct. Correct. This is something that we've tried to make this place a one-stop shop. Hopefully we can provide a lot of patient services to our patients and keep them here, and then talk to our colleagues if we need help, and work together. But that's what we're trying to do, and hopefully
Cool.
it'll continue to grow.
Anything else that I might be missing that we should
Um,
know on?
No, I think one of the things I wanted to talk about, there's first, so the budesonide, there's now a slurry that comes already ready. It's called Eophilia. And it's a lot easier to use as a topical steroid. Before, we used to have our patients have to like mix slurry with the medication with Splenda, all that, and it's worked out. And actually now there's a phase 3 trial of fluticasone that's coming out, dissolvable tablet that can also help
Oh, that's cool. I was not
patients
aware of that one.
to take that. Yeah, yeah. And then there are other trending medications they're looking into later on that might help not only in EoE, but maybe like eosinophilic gastroenteritis. They're looking at JAKs and then also vedolizumab. And there's some studies that looked at help with both IBD and EoE. So in that case where we had that patient who looked like EoE, let's say we treat him for his IBD, still having the eosinophilia, then maybe it might be a better, like Vito might be covered, two things might be better than just one in addition. So
Good to know. So it seems like it's a few new drugs
yeah,
coming down the pipeline that will help patients
yeah.
on their treatment. That was excellent.
Thank
Thank
you.
you for your help, and we are going to keep interacting with you,
No.
and and thank you.
Thank you. I appreciate it. Happy to help.